I have an amazing case to show you guys today, and I think it really illustrates why internal medicine is such a great specialty. It's a case where things could have easily gone very differently for the patient, but one single small detail completely changed the case and the patient's care. As always, I have modified some of the details of the case in order to protect the patient's privacy. So this is a case of a 31-year-old man with no significant past medical history presenting with face and neck swelling for the past 4 days. He reports that because of this face and neck swelling, he has had some difficulty swallowing over the past several days, also has had some difficulty sleeping, mainly because he feels that he needs to catch his breath in the middle of the night. He reports that his symptoms seem to be most prominent in the morning, and he actually presented 2 days ago to the ED. Mainly at that time, his complaint was a headache when he was lying flat, and so a full neurologic exam was conducted, a CT head was obtained to rule out intracranial bleed or intracranial process, and after that returned negative, he was discharged home. They ended up asking some additional questions to the patient. For example, had he started any new medications or supplements recently, and he basically denied any new medications, supplements, or vitamins. And then they also asked him, had anything changed in his diet recently? And he said, not really, but potentially the day before the symptoms started, he had been given some canned wings by his coworkers, as well as some Gatorade, which he does not normally drink. Now, I don't really know what canned wings is, but this is basically verbatim from the patient, so that's what we have. All right, so that's basically his history. And then we did do a review of systems, which was positive for dysphagia, a little bit of swelling in his feet that he noticed, as well as that intermittent dyspnea, and was negative for odynophagia, fevers, and chills, although he later stated that he may have had a fever at one point. No nausea, vomiting, or diarrhea, and no night sweats. So past medical history, past surgical history, family history, medications, allergies. Basically, he had no history at all. He kind of had not that much contact with the medical system, but was not taking any medications, had no relevant family history, and no known allergies. And then in terms of his social history, he reports he works as a landscaper, does not smoke or use any drugs. He does drink about 3 beers on Fridays and Saturdays. All right, and that's pretty much it for the initial history. And now at this point, I think it's an appropriate time to do a problem representation. And when you're making the problem representation, I kind of want you to put yourselves in the shoes of the ED physician, who is the first person who's going to be having contact with this patient. So take a second to see what you would put down in your problem representation, and then I will show you what I think a reasonable problem representation would be. And this would be a young man with no medical history presenting with acute face and neck swelling and shortness of breath. And immediately, this should already be triggering some illness scripts or differentials for you, especially in the setting of a patient that's presenting to the emergency department. So a lot of times, the emergency department, of course, their job is to rule out emergencies. So we have to first take a look and see what are the things that could really be immediately life-threatening to the patient. So some things that could potentially fit this problem representation would be something like anaphylaxis. One thing we would be looking for here is low blood pressure, respiratory compromise. Angioedema could be causing this kind of diffuse face and neck swelling. You have retropharyngeal abscess. This would be suggested if there is pain with movement of the neck. So if there's neck pain and if he has fever, this could be something to consider. You could also consider Ludwig's angina, and this would be kind of that really rapidly spreading cellulitis at the floor of the mouth, which is usually in the setting of a dental root infection. So if they had any recent dental procedure, this is something you could consider. And then one of the things that I interestingly learned while I was prepping for this talk is that there's something called the double tongue sign. And so here's an example here. You kind of have this elevation of the lower part of the mouth. And so it almost looks like you have 2 tongues in the mouth. And so that would be a sign of Ludwig's angina. And you may also see trismus, which is painful jaw movements that make it hard for you to open your mouth fully, as well as on board exams, they really like that firm, woody edema of the mouth. You could have something called Lemire's syndrome, and this would be in the setting of a recent strep pharyngitis, basically getting a septic thrombophlebitis, where you get basically an IJ, internal jugular vein clot that causes neck swelling and pain. You could have epiglottitis. You'd be looking for inspiratory stridor. You would also have a fever and muffled voice. Peritonsillar abscess. What the board exams really like on this one is a hot potato voice, but you're obviously going to look for that unilateral tonsillar swelling when you look in their throat. And they may also have trismus. And then another thing to consider is SVC syndrome. So if somebody has a tumor that is causing a clot or something in their superior vena cava, you're going to have backflow of all of that fluid into their face and their neck, and so everything is going to be swollen. And one of the things that you can remember as an interesting exam finding is the Pemberton's sign. Basically, this is having the patient lift their arms up, and if that causes flushing and redness and worsening congestion in their face, then that would be consistent with this sign, which can be a sign of SVC syndrome. So we'll take a look at Pemberton's sign. And this is a really great example right here. So when he lifts his arms up, it further occludes the SVC, worsening the signs of SVC syndrome. All right, so if this is your initial differential of can't miss diagnoses, life-threatening conditions that need immediate management, what would be your initial immediate management steps? What workup would you want to do? What initial labs and imaging would you want? So of course, the first things that they evaluated was the patient's airway. And who would you consult to evaluate this? Well, they ended up consulting ENT to do a laryngoscopy. And then they also obtained a CT of his neck to see the extent of swelling. Also just getting basic labs and vitals. All right, so here's his data. So his temperature was 99, blood pressure 160/100, heart rate 98, respiratory rate 16, and satting 96% on room air. In terms of his physical exam, it was documented that he had swelling of the face bilaterally, starting below the eyes and earlobes to the base of the neck. They did note some abnormal extraocular motion and injection, had full range of motion of his neck, but it was swollen. In terms of his labs, a CBC was obtained, a comprehensive metabolic panel was obtained, ESR and CRP were pretty low/unremarkable. Let me hide my webcam real quick so you can see that. But is there anything here that is initially standing out to you? Now, this is a ChatGPT generated version of what the patient looked like. I didn't specify any details about the patient, but I just tried to tell it to make somebody with like a swollen neck and swollen face. And then it went kind of overboard on the neck, and I kept telling it to reduce the neck swelling. And then it said I was at the limit for the images for the day. So this is the best that I could get from ChatGPT. I ended up going on Google and then finding something that might have looked a little bit more similar. So this is obviously a different patient, but I just saw this image on Google and just kind of diffusely swollen like this. This looks like a before and after picture after this patient was treated. So CT neck was also obtained, as I mentioned earlier, and you can see that there is just quite a bit of swelling and then some posterior pharyngeal edema. I believe if you look here, this is a little bit swollen compared to normal, but the airway is otherwise fairly patent. There's no focal areas of narrowing or concern for impending respiratory compromise. So the read came up as diffuse subcutaneous edema in the anterior neck and submandibular soft tissues, as well as prominent retropharyngeal edema extending through the neck, concerning for angioedema. No enhancement to suggest an abscess or focal area of edema to suggest soft tissue infection. ENT was consulted for scope visualization, so they ended up doing a fiber optic endoscopy, and overall, they really didn't notice any signs of airway compromise, as I mentioned before, and everything looked fairly normal. They didn't really see anything grossly abnormal. So on their note, they said, given these findings, there is no evidence of Ludwig's angina. The patient has a diagnosis most consistent with angioedema of unknown etiology. Low suspicion for infectious etiology at this time, and the differential includes allergic versus idiopathic versus hereditary angioedema. So they recommended admission to medicine, do not discharge without discussing with ENT team, and then starting some steroids. All right, so very briefly, I wanted to go over angioedema and how we categorize it into two main categories. So this is not something that as hospitalists, we are typically running into a whole ton, because a lot of these patients are either managed in the outpatient setting or they are managed in the ED and then discharged without ever being admitted to the hospital. So the two main categories that you should know of is that you have mast cell mediated and then you have bradykinin mediated angioedema. So the main thing that differentiates mast cell mediated angioedema from bradykinin mediated is that it is associated with the presence of urticaria or hives, whereas bradykinin mediated does not have urticaria. Another difference is that bradykinin tends to have a slower onset, and you can remember that by thinking that bradykinin-mediated angioedema is Brady. It's a little bit slower, and then it has a little slower offset as well, and it often doesn't have a clear trigger. On the other hand, mast cell-mediated angioedema does usually have a clear trigger, especially when it is the typical IgE/allergic-mediated angioedema. You also have anaphylaxis, as we mentioned before, and the way you differentiate anaphylaxis from angioedema is either going to be presence of another organ system that's involved, and typically the ones we think of is going to be your cardiovascular system, so you're going to see hypotension, or your respiratory system, so respiratory compromise. Other things that can cause a mast cell release that we commonly see would be opioids. So think about all those patients that get IV dilaudid and they have itching afterwards, as well as IV contrast. And then you have some patients that have this kind of chronic urticaria diagnosis that I've seen on the outpatient setting. So this is kind of your mast cell mediated causes over here. And then in terms of the bradykinin mediated causes, the first one we often think about is going to be your ACE inhibitors. Then you have hereditary angioedema, and then C1 inhibitor deficiency. So one question to ask is, with ACE inhibitors, when will you tend to see angioedema? Would it be after a dose increase or right after initiating an ACE inhibitor, or can it happen many years down the line? And so the answer is that ACE inhibitor angioedema can happen at any point after the patient starts taking it. So it could be 10 years later, they've had no problem with ACE inhibitors, and now suddenly they're having an angioedema event related to it. So this could happen at any time. Hereditary angioedema, you're usually going to be thinking about younger patients, and usually they have a positive family history. And then for the C1 inhibitor deficiency, this is usually going to be older patients. And this is often something that they even call acquired C1 inhibitor deficiency, because it's something that develops later in life. All right, so what do we think is the most likely for our patient? So the patient didn't have any urticaria, so it's unlikely that it was under this mast cell mediated category here. And then for bradykinin mediated, no history of ACE inhibitor use. He is a younger patient, but he has no family history and no prior episodes of angioedema, so makes hereditary angioedema less likely. And then he's, again, a younger patient, so less likely to be C1 inhibitor deficiency. So there is this kind of catch-all category at the end as well that's just called other. And so basically the main one that you have to think of here is going to be idiopathic angioedema. There's a bunch of kind of more esoteric ones as well, but for the main one that you need to know, it's going to be idiopathic angioedema, which is relatively common, and this one can be associated or not associated with urticaria. And you can see that this kind of schema was taken from the Clinical Problem Solvers, who has this on their website. So here you can see the mast cell mediated causes here, bradykinin mediated causes here, and then your other category over here. So really quickly touching base on treatment and workup. So for mast cell mediated angioedema, it can be treated with steroids plus antihistamines. Whereas for bradykinin mediated, it's really not that effective to treat with steroids and antihistamines. So maybe not so much of a role here. There is, C1 inhibitor replacements that you can give people if they do have C1 inhibitor deficiency, but really it's kind of removing the offending agent and then kind of managing symptomatically. And then in terms of workup, it really is not recommended to do further workup for clear mast cell mediated angioedema, but kind of for these other causes, they do recommend getting a CBC with differential, a comprehensive metabolic panel, a C4 level, which helps you figure out if it's hereditary angioedema or C1 inhibitor deficiency, as well as ESR and CRP. All right, so let's go back to the case. So hospital day 1, the patient was admitted to internal medicine, and in their note, they wrote that there was evidence of angioedema on imaging, also likely with gut involvement. There's an unclear trigger, so likely more idiopathic angioedema. So if you actually look on UpToDate, you can see that bowel edema and gut involvement is actually quite common with angioedema. So this is not a rare thing. The patient was started on cetirizine 10 milligrams daily and prednisone 40 milligrams daily. Again, not super clear if this would have been very helpful because it was thought that he had probably more of a idiopathic angioedema without urticaria. They did obtain some of that additional workup, so ESR, CRP, C3, C4, and LFTs. They recommended an outpatient allergy consult, and the sign out that I received was that, kind of follow up on this patient in the morning, and if his swelling is going down and he's feeling better, he can likely discharge home. So I'm going about my pre-rounding process, and I'm like, okay, this is a really simple case. This patient came in for angioedema, sounds like he's stabilized, and probably can just discharge later today. But when I go to see him, he's basically like, hey doc, my swelling really hasn't improved at all since I've been here. And then as I'm doing my normal physical exam, I was actually a little bit surprised about the degree of his lower extremity edema. It was about 1+, so not the craziest, but it still surprised me. So after I saw him, I saw the rest of my patients and then started getting work done. But the whole time I was just kind of scratching my head because I was trying to figure out, can I discharge him? The main reason that he came in with this diffuse swelling, we haven't really fixed it. But that at the same time, what am I doing that requires inpatient management? Right now, we're just giving him basically Zyrtec and prednisone, both of which are oral and can be done at home. And then I was also trying to figure out, if I do send him, what would I send him out with? So I was kind of running this case by my colleagues. And the whole time I was also, kind of confused. I was trying to mention, he has lower extremity edema as well. And then when I was saying that to my colleagues, I was kind of like, it's kind of weird because it doesn't seem like that fits with angioedema. So the day kind of goes on and I'm still, doing my other patient care work. And then all of a sudden this social work note pops up. I just clicked on it. I read it very briefly, but just reading this, there was one thing in here that kind of totally changed the way that I was thinking about this case. And it was kind of like a light bulb went off when I read this. So you may have caught it, but the main thing that really stood out to me was that the symptoms had actually been going on for a lot longer than we were expecting. So 2 weeks. So I actually ended up going back to the patient and asking him about the timeline of how everything had been progressing. And basically it was a language barrier and a miscommunication because he said, on Thursday, that's when all of my symptoms started. But actually he had been talking about the prior Thursday. So it was closer to about 2 weeks of symptoms rather than 4 days of symptoms. So immediately I'm already kind of thinking about the case a little bit differently because what kind of angioedema lasts 2 weeks? So I ended up going back through his chart and kind of looking at things with a different light and trying to see if there was anything that stood out to me. So let me turn off the camera again. And you may have caught this the first time around or you might have missed it, but now knowing that the patient's symptoms had been going on for about 2 weeks now, is there anything else that you're taking a look at in the labs here that might potentially stand out? I'll give you a second to take a look, and then I'll tell you what caught my eye. But what really caught my eye, and I probably really just kind of glanced over the first time because it seemed like a cut and dry case, was the albumin of 2.2. And then also I was going back and thinking, people can have hypercholesterolemia, hyperlipidemia, but 271 in an otherwise healthy 30-year-old, that's pretty abnormal. So now with these two new lab values and this new time course of his disease, is there a new problem representation that we can use to kind of frame this case? So initially we had a young, previously healthy man presenting with acute face and neck swelling and shortness of breath. So that totally led us down that angioedema pathway. And I think everybody initially, kind of anchoring down on angioedema, the most life-threatening thing, was very, very much appropriate in the moment. But now as we're getting more information, we can start to change our problem representation. So first of all, let's change this to subacute. So the patient has been having about 2 weeks of symptoms. This is not an acute process. And also, he wasn't having just face and neck swelling, but also was noting some belly swelling and some leg swelling. So let's add in some of these extra details that we've learned about. So subacute face, neck, and extremity swelling, hyperlipidemia, and hypoalbuminemia. So now we're already starting to get closer to potentially an illness script that you may recognize. And is there any way that we can make it a little bit more concise, talking about all this generalized swelling all throughout his body? So maybe we can change that to anasarca, which more concisely encapsulates the entire picture that is going on, and even more closely gets us to a specific illness script. So now that you have this new problem representation and you're thinking about this patient a little bit differently, is there any additional workup that you'd want to order now? So think about what you would want to order, and then I will show you everything that I ordered. So you can pause the video right here, write down everything you want to order. Basically, everything I showed you earlier was all the stuff that he had. He didn't have really any further workup besides those labs and initial CT neck imaging. So let's take a look at what I decided to do at this point. So I got an echo, a chest x-ray, and a BNP. Mainly this was to make sure I wasn't missing some other cardiac cause that could be explaining his generalized swelling. This is really just to rule out other causes and make sure I wasn't just anchoring on one specific diagnosis. But really, where the money was at for me was getting a urinalysis, which had not been done on admission. He didn't have any urinary symptoms. They all thought this was angioedema. There wasn't really any strong reason to get a UA. So a UA with a urine protein to creatinine ratio, also a microalbumin ratio, and then a nephrotic syndrome workup. So anti-PLA2R, we use this to check for membranous nephropathy. Hepatitis B and C, a lot of times this can lead to secondary membranous nephropathy or secondary MPGN, so that's why we check that. HIV can lead to FSGS. ANA, anti-dsDNA, we use those to look for signs of lupus, and then complement levels, kappa lambda free light chains, and SPEP. This is kind of an order set that I just have that pre-populates. And then the patient had not been getting DVT prophylaxis because they were a young, healthy man who was ambulatory. But knowing that I was suspecting nephrotic syndrome, that I decided to add Lovenox for DVT prophylaxis because, remember, in patients with nephrotic syndrome, they're losing all of their antithrombin 3 and they are becoming hypercoagulable. So adding some DVT prophylaxis is very, very much a good idea. Also, just getting a renal ultrasound just to kind of clarify what the kidneys are looking like. And then if significant proteinuria is confirmed, then I would consult nephrology. So here's some of the initial workup. So the echo did come back. It was normal, no signs of heart failure. His BNP was normal. Kappa lambda free light chains were both slightly elevated, but in a 1-to-1 ratio. So it's a very common mistake to see that both of these are abnormal and then think that some kind of monoclonal gammopathy could be going on. But what you're really looking for in that scenario is one of them to be extremely elevated and disproportionate compared to the other. So you're going to see a big change in the ratio. In patients with any kind of chronic kidney disease or kidney dysfunction, they tend to get some mild elevations in their kappa lambda free light chains. So don't be surprised when you see that you have some minimal elevations. His ANA was positive, but anti-dsDNA was negative. Complement levels were normal, and then his hepatitis and HIV screening was all negative. Now we're going to the money. So his urinalysis came back, and he had small occult blood. He had greater than 500 protein. He had some white blood cells, red blood cells, some bacteria, and some hyaline casts. And then here, his protein to creatinine ratio had a spot protein to creatinine ratio of 1.7 grams. And so, I was kind of following this up in the middle of the night at like 8 or 9 p.m. when I had already gone home, just because I was so excited about this case and that this patient seemed to have nephrotic syndrome. So I saw this number at home and I was like, oh man, that's so useless. Like 1.7 grams per day, that's like not helping me because remember, what do you need for nephrotic range proteinuria? We're looking for greater than 3.5 grams per day. So just even at 8 p.m., I just decided to throw in the 24-hour urine protein collection. That way we could just get it started right away. And it eventually came back 24 hours later with 10.9 grams per day of proteinuria. So now we have everything that we need to finalize our problem representation of a young, previously healthy man presenting with subacute anasarca, hypoalbuminemia, and nephrotic range proteinuria. Again, these are the three components that you need to diagnose nephrotic syndrome. And so ultimately, we were able to make the diagnosis. So moving on to the rest of his hospital course, Lasix 40 milligrams IV BID was started. Nephrology was consulted, and they had a plan for a renal biopsy with interventional radiology. And the biopsy results a few days later came back with a preliminary read of diffuse podocyte effacement on electron microscopy. So I want you to take a quick second and just put your nickel down on a diagnosis based off this biopsy result and what you know about this patient so far. What condition do you think their final diagnosis is going to be? And that answer is minimal change disease. So why don't we do a really quick review on nephrotic syndrome and nephritic syndrome? You can watch my full-length video on nephrotic versus nephritic syndrome, but some of the highlights really quickly. So nephrotic syndrome, again, remember you're looking for that greater than 3.5 grams per day of proteinuria. You're looking for anasarca and hypoalbuminemia. For nephritic syndrome, you will have proteinuria, but usually it's going to be less than 3.5 grams per day. And what you really want to be looking for here is hematuria with red blood cells, and then dysmorphic red blood cells and white blood cells, and CAS. And what I really want you to know is 3 main diagnoses for both nephrotic syndrome and nephritic syndrome. So starting with nephritic syndrome, you have your ANCA-mediated or your POSI immune causes. This is going to constitute about 60% of all diagnoses. The second category is going to be your immune complex mediated. So this is about 30% of all of the diagnoses. And then finally, you have anti-GBM. So these are the 3 main categories of nephritic syndrome. The main categories for nephrotic syndrome is going to be minimal change disease, FSGS, and then membranous nephropathy. For minimal change disease, remember on light microscopy, it's pretty much going to look normal because it's minimal change. That's why it's called minimal change disease. You don't really see that much. And then on electron microscopy, you're going to see that diffuse podocyte effacement. The treatment for this is generally going to be with steroids. For FSGS, what you're looking for is focal, which means that it is involving only some glomeruli, and then that it is segmental. So that means it's only involving some parts of the glomeruli. The treatment for this is going to be steroids versus calcineurin inhibitors. And then for membranous nephropathy, remember to check that anti-PLA2R antibody. You might remember the spike and dome appearance on electron microscopy. It's also associated with renal vein thrombosis. And the treatment is going to be either rituximab or some combination of steroids plus cyclophosphamide. For secondary causes, our most common one is going to be diabetic nephropathy. And remember, you're going to see those Kimmel-Steele-Wilson lesions and nodular sclerosis and mesangial expansion. Those are all kind of buzzwords for diabetic nephropathy. And then you also have amyloidosis. You have secondary FSGS. So this can be secondary to many different causes, including just obesity. It can be seen more commonly in African American patients, also HIV, lupus, drug use, and NSAIDs. And then you also have secondary membranous nephropathy from Hep B and secondary MPGN from Hep C. For the MPGN, one of the buzzwords that you want to know is the tram track appearance. All right, moving on to your ANCA-mediated. So generally, you're going to see normal complement. And then for your immune complex mediated, you're going to see low complement for all of the kind of post-infectious glomerulonephritides, so endocarditis, and then lupus. All of those are going to cause low complement, and then cryoglobulinemia also. Whereas you may have normal complement if you have IgA vasculitis or IgA nephropathy. And then going back to the ANCA-mediated real quick, so remember you've got your granulomatosis with polyangiitis. That's going to be associated with C-ANCA and PR3. And then you have your EGPA, and you also have microscopic polyangiitis, which is going to be P-ANCA with MPO. And then finally, for anti-GBM, you're going to be looking for that linear staining on immunofluorescence. And also, it may be associated with Goodpasture syndrome, which is when you also have lung involvement in addition to the kidney involvement from anti-GBM. All right, and so let's go back and discuss his overall hospital course. So the patient ended up having a positive quantiferon TB gold test. So in the setting of what we're likely going to be treating his minimal disease for, what do you want to first do now that we know that his TB test is positive? So basically, this was suspicious for a latent TB infection. So infectious disease was consulted, and the patient was started on isoniazid 900 milligrams weekly and rifapentine 900 milligrams weekly for a planned 3-month duration. He was started on prednisone 1 milligram per kilogram daily with a cap at 80 milligrams daily. And also, remember when you're starting those chronic steroids that you want to put people on the appropriate prophylaxis. So he was started on PJP prophylaxis with Bactrim, a little bit of osteoporosis prophylaxis with cholecalciferol or vitamin D, and then was also started on a proton pump inhibitor. Although I did recently read a Choosing Wisely Things We Do for No Reason that suggests that starting PPIs for chronic steroids is actually one of those things we do for no reason. The patient's hospital course was complicated by an AKI in the setting of starting an ACE inhibitor and being diuresed pretty aggressively. He was down about 13.2 pounds from admission. And the patient opted to leave the hospital before full resolution of his AKI, as he was anxious to get home and he had been hospitalized at that point for almost 2 weeks. There were initially some concerns for follow-up given his lack of insurance, but I did check his chart, and he did have a follow-up appointment already in place for 2 months from now with nephrology. So the patient hopefully will be linked in and be able to continue his treatment course as planned. All right, so that is it for this case. So an interesting case that initially presented as a possible angioedema. We kind of went through all of the life-threatening things that you need to rule out right away, and then also a basic schematic for angioedema and how to manage it, but ended up going back and refining our problem representation after knowing that the symptoms had been going on for about 2 weeks. It entirely changed the picture. And this is going to happen a lot in clinical medicine, where as you get more information, the entire diagnosis and diagnostic workup is going to change. And so you have to be adapting, you have to be flexible, making sure that you're not just anchoring or undergoing confirmation bias when you're seeing a patient. And so this was a really great case personally for me, because it was, like I said at the beginning of the video, one of those cases where it feels like you personally came in and made a big difference into the patient's overall care and what ended up happening to the patient. And I also mentioned this earlier, but I don't think anything that was done in the patient's workup was wrong. I think calling it angioedema too quickly before we knew the full picture may have been a little bit premature. But again, what are you doing in the ED and on the first day of admission? You're trying to stabilize the patient and make sure there's nothing life-threatening going on. And so for them to prioritize that, make sure that was not going on, I think that was totally appropriate. Just as the admitting hospitalist, you have to be aware that you are going to get more information, and it is going to change how you manage the patient. And if things are just not adding up and there's, you have this itching feeling that something is up or something is not quite right with the patient, you should trust your instinct and maybe do a little bit more digging, and you'll be surprised at what you find. Anyways, I had a ton of fun working up this case. I hope you guys enjoyed listening to it. Leave your comments down below, and until I see you next time, good luck and have fun.